Kan eh? Itu biar hot sign in juga. Biru kan?
Sign in.
Okay.
Yes.
Tak share ke?
Halo, yes.
Okay. Ada merah sorry. So, saya tak ada merah. Rotation 2 minggu. So, hari ni sudah tak ada merah masih. Present.
Pasal pagi, tanggal memang
Jadi, kita ni apa semua sana.
sebab kita dengan mendapat panggilan pasal
Boleh. Saya nak tengok aku tak jadi.
slow sikit lah. Kita start 8-10 kali kan kita start memang suarakan.
Boleh. Sampai pukul 9.
Kami jawab sambung yang MSQ. Selepas kita present nanti selepas habis terus open to question soalan nanti baru kita answer untuk Q&A.
Okay. Kalau start awal tak boleh?
Start awal
Ladies and gentlemen, we are about to begin shortly. Please be seated and ensure your mobile phones are switched into silent mode. For attendance, kindly scan the QR code displayed on the screen. QR code is also available on both sides of auditorium's wall. Assalamualaikum warahmatullahi wabarakatuh. A very good morning to our honorable guest, Dr. Putri Nurbaya binti Muhammad Ismail, Hospital Deputy Director, Head of Departments, Specialists, Medical Officer, Nurses, and the rest of respected Hospital Raja Provinsi staff. Thank you all for joining our today's CMP session. I am Dr. Suraya from Oral Maxillofacial Department, will be your MC today. Without further ado, I would like to invite Dr. Muhammad Haikal bin Abdullah Zawabi to present today's CME with the topic of cow milk protein allergy. It's not as rare as you think. Please welcome.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Suraya. Dr. Hana, consultants, HODs, specialists, and staffs. Thank you for giving me an opportunity. So I'm going to share about the cosmic protein allergy today. Okay. So first of all, why I chose this topic. Actually, as we know that this week is a week of the breastfeeding. So this is my disclaimer. Actually, I'm not contradicting or conflicting that I'm not also not going to promote regarding the formula feeding. Or special feeding, but in a way, actually, in conjunction to promote the breastfeeding. At last, the breastfeeding is the best. It's a treatment also, and also the preventive measure for this cosmic protein allergy. So, the cosmic protein allergy is also an important topic that is because of the commonest food allergy in children. However, it is underdiagnosed and also under-reporting. So I would like to create an awareness regarding this disease and also this illness that can be happen in our children, or maybe our friends with children. So this is guideline just recently published in Malaysia. This is second edition. The first edition is 2012. And this is the second edition revised back in 2014. We just recently relaunched in the Royal Chulai Kuala Lumpur during the biennial scientific congress, 28 June. And actually, it recommends for diagnosis and also management of the CMPA. And these guidelines is offers a practical approach with the diagnostic algorithm based on the evidence-based guidelines. So what is cosmic protein allergy? Is it common? I think some of us may be experienced with this situation, but we didn't aware about that. So I give some of the case illustrations. The first case is a 3-month-old who is formula fed, has no eczema, has breakage after feeding, normal stool, but frequently unsettled, crying in the evening. And this lasts about a few hours and then after that resolve. So was it IgE mediated CMPA or non-IgE mediated? Or maybe it's an infantile colic, or maybe it's a reflux. So we discussed after this. The second case, Nawal, 8-month-old, was brought by his parents who are concerned about his allergy. Nawal was given yogurt for the first time at 10-month-old, and developed urticaria around his face, across his face, and also mild swelling of his eyes. No treatment given, and symptom resolved after 1 hour. Otherwise, it was fine. And Nawal actually is exclusively breastfed. No, so far, Nawal was given some fruits and also vegetables with no concern. So it is IgE mediated, or non-IgE mediated, or perhaps it's just viral infection. Okay. And then the third case history, Sarah 3-month-old boy was born at term, needed IV antibiotic for the MAS. Actually, Sarah is a breastfed baby, but within 2 months, developed eczema. So I think it's typical. Okay. And then she constantly unsettled, crying, had multiple visits to primary clinic or emergency department, and she frequently vomit after feed and has frequent explosive diarrhea with blood in stool. So we take care of it. Is it CMPA or is it just acute gastroenteritis AGA or maybe is it dysentery? Some of us will treat as a dysentery. So we talk about that after this. So all of these three is what we should give advice to the mother. Either to change to salt-based formula or extensive hydrolyzed formula, tapi mahal lah. Continue breastfeeding, exclude all the milk or soy product from the diet, or maybe start oral antibiotic and to treat infection. So for the overview, regarding the cosmic protein allergy, it is commonest food allergy in children. About 3% globally the prevalence. 3%, okay, but Malaysia, we lack of data. Very small of the healthcare that reports on the CNPA. But in Asia, it's about the 0.1 to 3%. So let's say in this auditorium, about 100%, 100 people. So we need that 3 of us have CNPA. So actually, he has the CNPA has a significantly financial burden impact to the families because they have to change the formula frequently, and the symptom is preserved and recurrence. There was 2 studies, retrospective studies that have been done in UK and also I think in South Africa. They have monitor baby from the start of the diagnosis until 1 year old. They found that the cost that involved in treating the patient is about 8,000 to 10,000. Actually, it's in the euro, about 1 to 2,000 of euro. They estimated the cost. They have to go to the clinic multiple times, the fee of the consultations, and also the recurrent and multiple formula made need to be changed. So this include to the cost. So at last, our strategy is actually to shorten the time of the diagnosis to reduce the cost and also we shorten the treatment. So we go to the clinical features. CMPA can be presented with many organ or system involvement. The first one, the most common is GI, about 60%, and presented with the recurrent regurg, vomiting, diarrhea, constipation, and blood in stool. Second is skin can be up to 90%, presented with the atopic dermatitis, angioedema in the form of the swelling of lips and also eyelids, and also maybe urticaria. But this urticaria is not related to the infection. We have to exclude this infection and also drug related. And likely is an IgE mediated CMPA. Respiratory also common, came with runny nose and also otitis media, recurrent otitis media, frequent, and can be also chronic cough and wheezing. And systemic also can present with the persistent discharge that may require of multiple admission because of pneumonia. We think I have pneumonia, but the parameters are not so significant. Maybe the total what is low, CRP is low, but presented with the recurrent cough. So we need to think about CRP. Colic, the children can be presented with the irritability, crying more than 3 hours for the whole 1 week, 3 days, 3 hours, and also iron deficiency anemia. So history taking actually very important. So is this CMPA, which system is involved? So we have to ask ourselves, either GI or respiratory or skin or maybe generalized. And then the history of exposure to the cosmic protein, the time of reaction. We give the formula mate, and after that, within 2 minutes or 2 hours, the symptoms is developed, or going to develop. Or maybe delay in the onset of 40 hours, or maybe weeks. And the history of maternal dietary history. The mother consumes the formula milk, and this is also important, especially in the exclusive breastfeed infant. Any concomitant atopic condition, like the patient have atopic eczema, allergic rhinitis, asthma, or food allergies, this will increase the probability of CMPA. Any family history, of course, we need to ask about the family siblings. And the last one, we have to exclude the infection. The infection will have to be excluded first. So for the first classification, we have IgE mediated, non-IgE mediated, and also mixed. For the IgE mediated type, it occurs about 2 hours of exposure. After 60% of the case can be presented after the first exposure, but doesn't mean that after the first exposure, it's not likely a CMPA. 40% of the remaining maybe develop the symptoms after the repeated exposure. Okay. So about the systemic reaction, they presented with the first one is very severe anaphylaxis, the occur minutes and also hours that involve the skin mucosa, dyspnea, bronchospasm, hypotension, shock, multiple organ involvement, organ dysfunction, and GI symptoms. For the GI manifestation, actually less common in children, lip swelling, vomiting, and diarrhea, and mimic AGE punya symptoms. For the respiratory, dyspnea, bronchospasm, stridor, hypoxia, asthma-like attack, and also rhinitis. For the cutaneous, for the immediate onset can be acute urticaria, angioedema, contact urticaria, late onset of atopic dermatitis. But for the non-IgE mediated, they're more prominent towards the GI manifestations, and also most of them is chronic. So there are GI spectrums that we need to, I think we need to try to understand for now. Some of the new diagnosis that have been made, food protein induced allergic proctocolitis, we call it FPIAP, or food protein induced enterocolitis syndrome, FPIES, or CMP induced enteropathy ataupun FPE. So what's that? This is a GI spectrum that can be occur all of this and can be overlapped with the each symptoms or signs. For the food protein induced allergic proctocolitis, the symptoms actually present the second month and also can be earlier from that, mimic the Hirschsprung disease, and they have made normal stool or maybe the mild diarrhea and also the bladder bleeding. But otherwise, typically they are thriving, berat naik semua, and to also typically well, and maybe also in exclusively breastfeeding infant. For the FPIES, food protein induced enterocolitis syndrome, present about 1 to 3 hours following the injection of CMP. They represented with the vomiting, hypotonia, pallor, and also diarrhea, and can be severe cases like a dehydration and a shock, and may be caused by the other food protein that has been reported in the exclusively breastfeeding infant. For the CMP enteropathy, ataupun we call this as a food protein enteropathy, it is chronic of the FPIES that may present with the diarrhea with or without blood, and also failure to thrive, hypoproteinemia, vomiting, and also anemia. And this type had a clinical sign of the secondary lactose intolerance may coexist. Others of the GI manifestation, they can present with the colic, which is the cause is unknown, and also multiple factors like esophagitis can be constipation, but it is controversial. We need to exclude the other causes, and we have to know that the functional constipation is the most common cause of constipation, and may also present with the symptoms of gut reflux. Because of what the mechanism, the cow's milk can induce the gastric dysarrhythmia and delay the gastric emptying. That's why the patient will be crying after feeding. So we have to monitor that. That non-IgE mediated for the GI manifestation. The next is respiratory reaction. There is one condition or syndrome we call it as a Highness syndrome. Highness syndrome is a rare allergic disease that because of the abnormal reaction to the cosmic protein and in the form of the chronic pulmonary disease. This one if the patient admitted to our ward with multiple history of chest infection, but actually cannot be detected from the culture, the MPA or MPS negative parameters is negative, so we have to think about this. They characterized by the recurrent pulmonary infiltrate. You can see at the chest X-ray, a lot of the pulmonary infiltrate are heterogeneous opacity. And then from the CT, and also we show the diffused bilateral symmetric alveolar infiltrate, or by the bronchoscope, the lungs showing the brownish discoloration, and under the microscope, we can see the macrophage in alveolar spaces. And usually the patient or children will be presented with chronic cough, recurrent fever, chronic cough yang tak resolve, recurrent fever, tachypneic wheezing, rattling sounds, crepitations, failure to thrive, and most important is family history of CMPA. We should consider in infant with unexplained chronic pulmonary infiltrate. So for the mixed IgA or non-IgA mediated, okay, like atopic dermatitis, respiratory manifestation like rhinitis, laryngeal edema, bronchospasm, cough, GI, then GI actually like a non-IgE mediated, they have been prominent with regards of the symptoms. So it can be eosinophilic GI disorders, allergic eosinophilic AGE or eosinophilic colitis. What are they? The eosinophilic GI disorders is predominant with the symptoms of rigors. But when we start the anti-reflux medication, it will be poor, not responding to the anti-reflux. The presentation is a regurgitation, vomiting, rumination, lost appetite, also burning or crying after feeding. So we have to do that. Sometimes with the sanguifular syndrome. So at last, we be swallowing difficulty, food impulsion. The children refuse the food, aversions, feeding difficulty, and last will be failure to thrive or go again. The second one is allergic eosinophilic gastroenteritis. The hallmark is the eosinophilic that infiltrate the gastric side of the duodenal mucosa, causing the abdominal pain, irritability, easy satiety, vomiting, diarrhea, weight loss, anemia. You can see the anemia and also hypoalbuminemia, which is because of the protein losing enteropathy. And the last one is eosinophilic colitis. With the words of colitis, the prominent at the colonic mucosa, the majority presented with the chronic diarrhea. So what are the investigations we can diagnose the CMPA? The first one is we have to eliminate the cosmic protein, and we did the challenge test. This is a confirm of diagnosis. And the duration of resolution of symptoms will be varies according to the type, IgE and IgE. Some will be resolved after 1 to 2 weeks, some will be more longer. And it's also practicality is good and sufficient to diagnose the cosmic protein allergy and how to do the OFC. Oral, we call it as an oral food challenge. So when to do? When we need to confirm. and also evaluate the CMP tolerance. Timing, about 2 weeks after the resolution of the symptoms, we stop the formula feed, and then we see that after 2 weeks the resolution, or maybe 6 to 8 weeks in the patient with chronic atopy or eczema. When not to do, when the patient have anaphylaxis. Kita tak boleh challenge kalau patient ada severe symptoms like anaphylaxis or during the elimination phase. What are the relevance? Let's say kalau kita buat OFC, oral food challenge, and also we have the reaction, so diagnosis is confirmed. Second thing is, if negative, we can exclude the CMPD. And how to do? You can see the checklist from the CPG. So the pre-test, how to do the oral food challenge? First, we avoid the medication, antihistamine, steroid, beta blocker, and should be performed in clinical setting. And the choice of cosmic from the less 1 year cosmic infant protein. During the test, we introduce the meat in a graduated incremental manner every 20 minutes. So at 0 minute, we give 1 meal. We challenge. We look for the symptoms and signs. Identify and monitor the occurrence of symptoms. 20 minutes, we increase to 3 min. 40 minutes, and we increase to 9 min. And at last, at 80 minutes, at the 90 mils, about 3 ounces. So, during that time, if any positive sign, we stop the challenge. And then we document the amount of the milk ingestion, and also we need to monitor the saturation, vital signs, and also symptoms that can be delayed. We need to observe more than 2 hours post oral food challenge. The post test, if normal, we can discharge, and we advise the mother and monitor the symptoms at home and continue the administer the milk, the cow's milk, to about 200 ml at home for at least 2 weeks. So the next investigation we can do skin testing, skin prick test. If the test is positive, actually is showing that the children has the previous sensitization before. But if we tie with the clinical features, it is predictive to the IgE mediated. It will be, the response will be the wheel formation, urticaria, and it's negative. If the test is negative, 90% will exclude the IgE mediated CMPA. Sorry. This is another test of the testing, atopic patch test, much lower sensitivity, and we also have the intradermal skin test, but not included in CMPA. The third one is serum IgE. We evaluate the serum for the specific IgE. So we look to the measure the cosmic serum immunoglobulin of E, and then the value, if let's say they're more than 0.35, is a positive test. But if no history of clinical features, it actually meaning that it is sensitization, not allergy. But if with the clinical signs, so it is towards the CMPA. How about we use the serum IgE, and then we combine with the skin prick test. Actually, both tests will be high predictive, high negative predictive index. If negative, so meaning that we exclude the CMPA. So with the clinical application to diagnose to confirm the diagnosis, especially with the patient with the history of anaphylaxis. Okay, and then if let's say that we cannot proceed with the skin prick test, serum IgE alone is able to confirm the diagnosis of IgE mediated CMPA. The next one is the fecal calprotectin. We measure the level of the fecal calprotectin, but it's not recommended. It's for the diagnostic tools because of the limited data. And the last one is the basophil activation test, or BAT. They measure the expression of the CD203 and also CD63 upon the basophil when we give the allergen. And then we measure the activation markers, which is that CD, and we look for the measurement. It's actually good diagnostic profile, and the specificity is good, sensitivity more than 80 to 90%. So how to manage the CMPA? So outline, we the first one we need to dietary elimination, and then you can do the oral food challenge that I have talked before. Formula substitution. After this, I will discuss or stepwise approach using the different degrees of hydrolyzed formula. There is a role of monoclonal antibody or oral immunotherapy, and the most important is prevention. So the first one is dietary elimination. So with the allergy to the cosmic protein, so we have to eliminate, we have to stop. The key is dietary elimination of CMP, and we use the substitute formula. Use the substitute formula not only for the children less than 2 years and non-breastfeeding children. Okay, for the breastfeeding, continue breastfeeding. Periodically, we evaluate the tolerance to the cosmic every 6 months. Usually, at the 3 years old, the tolerance to the cosmic protein will be about 90%. So for the formula substitution, we have a lot of types of the formula meal, the special one. The first one is extensive hydrolyzed formula, such as an ultraminogen. But the issue is non-halal. It should be supervised by the clinical or dietitian and has residual allergenicity but low, about 2 to 8%, and very effective, about 90%. And actually, this extensive hydrolyzed formula is first line that recommended to substitute the formula. The second one, we have the hydrolyzed rice formula. We have novo rice, we have similar rice. Actually, it is a halal, and the source of the protein is from the rice. Its efficacy and safety is well established. A lot of study have been done and recommended for the severe CMP with the persistent symptoms of CMP or poor weight gain, even with extensive hydrolyzed formula. Kalau tak boleh extensive, kita go to the hydrolyzed rice formula. And we also have amino acid formula such as Neocate Junior, clopidogrel plus. This one is Neocate, sorry. Okay. So we have also soy-based formula such as Isomate, Duprosoy. Kalau more than 1 year old, we have Isomate plus Duprosoy. Actually, it's not recommended as a first line of treatment of CMPA. But you can consider if the infant more than 6 months or ataupun patient not tolerated dengan extensive hydrolyzed formula, or maybe because of the religious preference. How about the plant-based, such as kalau plant-based ni ada oats dan extra almond, and also goat's meat actually is not recommended for treating the CMPA because of the goat meat had high sodium, low folic acid that maybe risk to the hypothermia and hypernatremia and also megaloblastic anemia. Because of the goat's meat have allergenic in children with CMPA, about 90% they have reactivity. This is a stepwise approach using the different degrees of hydrolyzed formula. We start with the if patient have confirm the diagnosis of CMPA. So we start with the amino acid formula, and then if they tolerate, we can change after 1 to 3 months, change to the extensive hydrolyzed formula, and after that, change to partially hydrolyzed formula, and at last, if patient have tolerate well, usually at 3 years old, they have the good tolerance and can change to the intact cosmic protein. So in the management, we have monoclonal antibody. 2 monoclonal antibody have been researched before, omalizumab and also dupilumab. That have been approved by the US FDA. And this oral immunotherapy used in the IgE-mediated food allergy for the patient more than 1 year old, and for the reduction of the type 1 allergic reaction. And omalizumab, actually, one is a positive. The second one is the prolong of the treatment, about 16 weeks. There are 36 of meta-analysis that assessing the omalizumab, and at last they found that the omalizumab is increased, had ability to increase the tolerated dose of multiple food allergen, including milk, and also reduce the allergic reaction. So we go to the practical strategies, okay, to do the in the case of the CMPA. The first one in a patient with the exclude breastfeed. In patient with exclusive breastfeeding that we confirm with the CMPA, we continue with the breastfeeding with maternal elimination of CMP. Those are the mother who breastfeed, we're going to stop with dairy products. And then we look after 2 to 4 weeks. Let's say that the symptom is improved. So after 6 to 8 weeks, we do the oral food challenge with cow's milk yang kita tengok tadi, reintroduce the CMP into the maternal diet and continue breastfeeding. Maksudnya ibu tu minum sikit baru tengok symptoms dia. If let's say that symptom is reappear, the maternal elimination of CMP for the entire breastfeeding. So dia tak boleh nak kena elakkan dairy product in the punya maternal punya diet. If let's say that the symptoms do not reappear, so you can boleh continue with the breastfeeding without maternal elimination of CMP, and make sure that evaluation must be done every 6 months. Okay, for the patient with the formula fat, if the patient children presented with anaphylaxis or allergic EOE, so we stop the cow's milk protein, we use the amino acid formula, and then we re-evaluate after 2 to 4 weeks. And then the evaluation must be done in the tertiary hospital. We monitor the symptoms, monitor the also serum IgE, and do the open oral food challenge with the cow's milk and re-evaluate after 6 months. If the symptoms do not improve, so we need to consider with other diagnosis. In a patient who formula fed but with the presentation with no anaphylaxis, first we eliminate the cow's milk protein and we go to the alternative formula, amino acid, hydrolyzed formula, partially hydrolyzed, antacid hydrolyzed. And then after 2 to 4 weeks, we monitor the symptoms. Let's say that after 6 to 8 weeks, no symptoms or symptom is improved, we consider for the skin prick test and also monitor the serum IgE. And if normal, we will do the open oral food challenge with the cow's milk. And then during the challenge for 1 week, after that we need follow up. If let's say that symptoms do not reappear, we can consume and resume the CMP in the diet with the monitoring. But if let's say that during the alternative formula, the symptoms do not improve, we consider other formula daripada amino acid naik kepada extensive hydrolyzed formula, naik kepada hydrolyzed rice formula, naik kepada partially hydrolyzed. Kalau symptoms still lagi do not improve, so we need to consider the other diagnosis. Okay, yang tadi kalau let's say kalau kata bila kita challenge buat open oral food challenge, let's say kalau kata symptoms to reappear, we need to maintain the cow's milk protein free diet until 9 to 12 months, and then re-challenge balik after at least 6 months. So how about the follow-up? Actually, the cow's milk protein allergy has a good prognosis. 60 to 80% will be outgrown by the 2 years with the management, with the proper management. And by 3 years, we increase about 90%. And make sure that the timing re-challenge at least 6 months. And if the patient presented with a severe anaphylaxis, we have to delay the time of re-challenge up to 12 to 18 months. and re-evaluation every 6 to 20 months. During the follow-up, we need to inducing the tolerance to the cosmic protein. Actually, the cosmic protein, one of the most used of ingredient in our cook, daily cook. Cake, pastries, and some of the food also kita punya traditional punya makanan, kuih Kelantan. Ada sometimes tu dia campur dengan susu sejat, apa semua. So ada cosmic kat situ. So takkanlah selama-lamanya kita tak boleh nak makan kan. During the follow-up, we can induce the tolerance to cosmic protein. But for the non-IgE mediated only, there are two approach. And tadi kita dah discuss regarding the stepwise approach, guna yang hydrolyzed amino acid, adenine, pada extensive hydroformula. The other one is a meat-ladder approach. We introduce the meat and also dairy-based food. This is a widely practiced and potentially develop, allergic to the food, other food allergen. So for the meat ladder, we introduce the meat and dairy product into the diets gradually, sikit, berterusan, dan increase graduated. Why induce the accelerated tolerance in the step one approach of introducing meat product? Can be done in a mild to moderate non-IgE mediated CMPA in a home setting lah. But not for the patient with the history of anaphylaxis or control asthma. We need to regularly follow up 6 months. So the first step adalah kita we use the small amount of food protein. So contohnya ada kat situ muffin and also well-baked cookie. And then after that, kalau okay, we start with small amount in the diet. Can be daily and also every meal. And then after that, if patient tolerate, we need to go upward to wafer and also pancake. And then after that, pizza. So actually, this is this is used from the international guidelines, but we can readjust according to our setting with our food. The concept is from the small cooked protein until the last one is uncooked protein. Okay, this is some of our food that may contain of the cosmic protein. Roti canai hari-hari kita makan ada sweetened condensed of milk for the additional flavor, ditambah susu pekat. Kari ada content of ghee, ada buttermilk, evaporated, susu sejat untuk rasa sedap dan lemak. So boleh jadi can make the severe of the symptoms to the children. And also maybe yogurt. This one is a nasi minyak, nasi biryani. They use evaporated milk. How about the cake, donut, pastries? They use butter, milk, and also cream. Kuih-kuih kita orang Kelantan suka. Sometimes they guna evaporated milk. And also air, paling sedap diguna condensed milk, air balang, air teping, jagung, and even also ABC, they are condensed milk. So we talk about the prevention. As I said before, exclusive breastfeeding for at least 4 months may cause a lower incidence of having CMP at 18 months. But the others method like partially hydrolyzed, aesthetic hydrolyzed, soy-based, prebiotic, probiotic is not sufficient to support the prevention. And last is breastfeeding. So how about the CMPA or lactose intolerance? Are they similar? No, actually they are not. Cosmic protein allergy is protein, lactose is sugar. What is that? The cosmic protein allergy is allergic reaction to the protein, cosmic, and other types of the milk. In the cow's milk, dia ada casein, dia ada whey protein. But the lactose intolerance, the different in ability to digest the lactose milk sugar. The immune system that involved for the cow's milk protein allergy is multi-system, but the lactose is only GI. And then the tolerance, the small amount the cow's milk could cause the allergic reaction, but in the lactose intolerance, small amount of lactose tolerance usually can often be tolerated, and cow's milk protein does not cause any allergic reaction. So we go to the third home message. Okay, the first one is CMPA is one of the most common food allergies in infant globally, including Malaysia. The clinical presentation is actually diverse. Can be, but the most presentation is GI manifestation, and of course the clinical history is very important to diagnose the CMPA. And the most clinical situation, CMP elimination, and also open oral food challenge are recommended for the diagnosis. The breastfeeding is actually recommended for the treatment and also prevention. And extensive hydrolyzed formula is a first choice, while the hydrolyzed rice formula or amino acid formula can be considered acceptable alternative for the phenotype and severity, and also availability and also acceptability. And the last one is plant-based and also good meats are not recommended in treating for CMP. I think that's all. Before that, I think I proceed with the questions, right? Okay. So with that previous case illustration, we go back. For the case one, Siti is a 3-month-old who is formula fat, no eczema, ada some wrinkles, no stone, tapi frequently unsettled or crying in the evening. This lasts a few hours and then resolve. So which one? The more suitable for the answer? Anyone? Ada? Tak? Ada? Okay. Oh. Anyone? Is it IgE mediated? Non-IgE mediated? Is it infantile colic or miracle? Boleh teka. Okay, infantile colic, betul. Cukup sikit. Okay, for the second case, Nawal, 8-month-old, walked to his parents are concerned about the allergy after given yogurt, and then after that resolved in 1 hour, and then after that, well at that day, exclusive breastfed. However, the fruits, vegetables have no concern about the allergy. So which one? IG mediated, non-IG mediated viral infection? Oh, good. I think no. Okay. Which one? IgE mediated. Okay. Congratulations. And the last one is Sarah, 3-month-old baby was born at term, admitted because of MAS and a given antibiotic. After 2 months, developed of eczema. And then, but this patient is unsettled, crying. They have multiple visits, go to primary clinic, PD. Sometimes they frequent of vomiting after feeding, and frequent explosive diarrhea, and also blood in stool. Which one will be suitable? IgE, non-IgE mediated, or maybe AG? Or is it the same thing? Ada yang jawab? Dysentery. Okay, ada lain nak try? Kata nak tuliskan. Yes. Yes, dan IG media tu. So yang ni tak ada lah yang keempat. Okay, tak ada yang ni. What advice should be given to the mother? Sama ada change to soy-based formula, change to extensive hydrolysis formula, ataupun continue breastfeeding, ataupun start antibiotic. Infection pun kan, try infection. Usually we treat as infection first, right? Tak ada. Okay, so we continue with breastfeeding, exclude the all milk and soy product from the diet. So at last, breastfeeding is a treatment for the CMPA and also best prevention to prevent the CMPA. For that, I thank you and I leave it to the floor to have any questions.
Thank you, Dr. Muhammad Haikal bin Abdullah Jawabi, for the very good and informative presentation. We now welcome any question or opinions from the audience.
Yeah. So you mentioned about 80% because of the three years, I think. Yes. Is there any late onset in 6 years or to the
Okay, thank you, Mr. Nazim. Very good questions. Actually, with the not only cosmic protein allergy, the other phenotype also macam like allergy rhinitis, asthma, ada atopy punya manifestation. You can see the graph. So saya tak tunjuk graph. The graph for the cosmic protein allergy will be increase, and after that in 2 to 3 years they will reduce because of the body is developed the tolerance. About the late onset, they may present the late onset, but it can be other types, meaning that more towards mixed punya IgE mediated or non-IgE mediated or non-IgE mediated. Because of what? Actually, maybe they present in earlier, but we think about the other thing. Meaning that maybe if kalau datang dengan blood is tu, maybe dysentery first lah. But the symptoms is recurrent, and sometimes the symptoms of the infantile colic, they cry after feeding. So we thinking that oh maybe sebab lapar kan, so kita tambah feeding. So that's actually that happen in earlier, but the presentation is continue and become chronic. I mean that for the non-IgE mediated, they have the GI spectrum like food protein induced enterocolitis syndromes. That one is a chronic. So after that, we trigger. Then presentation more prominent. Maybe the onset of the 2 years or 3 years. But I think the presentation is earlier, so we have to catch up now. So I think my objective today actually to give an awareness also about the symptoms that we have to look thoroughly. The possibility of CMPA can be a possible diagnosis in our practice after this. Thank you.
If there is no more question, I would like to invite Dr. Putri Nobaya binti Muhammad Ismail to deliver the certificate of appreciation to our respected PCME presenter. Please welcome. Thank you, Dr. Putri Nobaya. With that, we have come to the end of today's CME session. The upcoming CME will be presented by Dr. Habibah binti Mat Said from Oral Maxillofacial Department with the topic of sharing of experience on nasoalveolar molding plan, the journey. Thank you everyone. Assalamualaikum warahmatullahi wabarakatuh.